Good afternoon. I think it is for everybody. This is Steve Pearson again at ICER. And welcome to the third in our installment of these webinars on perspectives on cost-effectiveness thresholds in the United States. For those of you who are following through the series chronologically, you've heard my brief introduction. But let me just state again, the goals of this was to benefit from the presence at ICER over a couple weeks of visiting fellows, Carl Claxton, Sean Sullivan, Jens Gruger, and Chris McCabe, and to generate a broader discussion across health economists in the United States, but also members of ICER's independent appraisal committees and stakeholders who are really part of a broader discussion as this has become an important issue, certainly for ICER's methodology. So the goals of these webinars are not, by the way, to try to pick a winner and a loser in the race to define what ICER's methodology will be. It really is to help us all take a step back and learn from the best current thinking, research, and ideas for what future research should look like to, again, help create a broader perspective on something that's so important to decision makers. So with that, we're going to introduce two of our speakers today. And we're going to flip the order in which we had originally intended on the paper that you may have in front of you. But the goals of today are to continue our discussion around willingness to pay as one approach to thinking about cost-effectiveness thresholds. So we touched on some of these issues when Chris McCabe gave his webinar a few days ago. Today we're going to talk more about, again, the many different ways you can think of willingness to pay, perhaps in particular past funding decisions, the value of a statistical life, and Chuck Phelps's recent work as well on relative risk aversion as ways of thinking about willingness to pay as the basis for cost-effectiveness thresholds. So with that, we're going to start with Chuck Phelps, whose academic appointment is at the University of Rochester. Apparently he's calling us from sunny Northern California today. And following him, we'll have Sean Sullivan. If you have questions or comments, please feel free to introduce them into the questions section of the toolbar that is at the right-hand side of the webinar, and we'll try to get to them towards the end. We will have responders to these presentations from Chris McCabe and from Jason Wasfy. So, Chuck, over to you.
Thank you. Delighted to be here, and thanks for organizing this. This is publication that just came out in Value in Health in July. So I'll have a very quick race through of it for about 10 minutes. Sean's going to talk about this in some detail following me, but past methods to try and determine the optimal cutoff include league tables, value of statistical lives, some direct willingness to pay estimates, and some work with Hall and Jones that estimates the cost of producing lives. I'm not going to dwell on these except to note that I have some fairly serious reservations about the value of statistical lives literature. I think it overstates the mechanism quite a bit. And I'll just comment that these are all methods to try and calibrate the optimal cutoff using different kinds of observable data. So that's the goal of this, and I have a new approach for that I'll be driving into shortly. The consensus numbers, of course, on this world range for about 100 to 150,000 in the US, and are often expressed in terms of multipliers of per capita GDP, such as WHO has done. And the British National Health Service has numbers that are under 1. Sweden's got a rule of thumb that's about 1. WHO has said up to 3, and ICER has said basically 2 to 3 in the United States with 100 to 150,000. The new method I have is straight economics. It's hardcore economic modeling. I'm going to define money as M and K as the optimal cutoff. And going back to the work that Alan Garber and I did, the optimal cutoff can be defined in a utility maximizing framework for a single individual as the ratio of utility to marginal utility. And from that follows the very simple observation that the ratio of K over M, the income multiplier, if you will, is the inverse of the income elasticity of the marginal utility of income. And that creates a very simple intuition, which I'd like to try and emphasize with you, and that is that this elasticity of utility with respect to income or consumption basically represents the opportunity cost of foregone consumption as you expand spending on medical care. This is a very straightforward result of the economic model, and I think a nice intuitive description. It says the more utility you're giving up, the higher that elasticity, the less you want to have, the smaller K over M value you want to have. And if you're not giving up much utility, if that elasticity is small, you're going to have a K over M value that's large. How should the value K change with income? For all utility functions, not just the specific one that I will use, the elasticity of K with respect to M, it turns out to be the sum of that elasticity of utility with respect to M plus relative risk aversion. And so that's in general going to be greater than 0. Since R star is greater than 0, the relative risk aversion measure. And if that ratio exceeds 1, then the elasticity of the income multiplier, K over M, is also going to be positive. And that's an empirical issue, which I will show some results on momentarily. My model is calibrated using measures of relative risk aversion. I'll talk about how I find those in a moment. Definitions, again, for those not familiar with this literature in finance and risk, are the absolute risk aversion is the ratio of the second to the first derivatives of utility function. It's a curvature, basically. It tells how fast utility declines with income. And R star, the relative risk aversion measure, is basically the negative value of the income elasticity of the marginal utility of income. So people talk about these. There's with absolute risk aversion, there's DARA, CARA, and IARA, declining, constant, and increasing absolute risk aversion, and comparable measures for relative risk aversion. In some work on finance that Ken Arrow published in 1971, he argued that we should have decreasing absolute risk aversion, but increasing relative risk aversion. I think subsequently, I'd say the literature generally agrees that we have decreasing absolute but risk aversion, but less clarity on the relative risk aversion behavior. That will matter a little in my work, as we'll see, but in general, I'm going to be working with a model that has DARA and increasing relative risk aversion. So the next step is to find a useful functional form. Work that I've done with Alan Garber and Feldstein and Friedman earlier, and then a more recent work, if I've used the constant absolute risk aversion function or constant relative risk aversion. These are mathematically convenient, but they turn out to be highly restrictive and in fact extreme edges of a more general model that I'll describe, which is the Weibull utility function. You can see it described down below. The utility is an exponential function of 2 parameters as well as money. It's parameters gamma and C. And it ranges from 0 to 1 as income goes from $1 to infinity, basically. And the relative risk aversion measure you see at the bottom of the screen is a combination of C, this parameter that ranges between 0 and 1 in the Weibull model, gamma, which has to be derived in money, income. This encompasses both the CARA and the constant relative risk aversion model as specific forms of it. So when you calibrate this Weibull model, when C is equal to 1, it's CARA, the model that Alan Garber and I used, and it's decreasing absolute risk aversion for all values of C less than 1. And when you get down to about C of a 0.5, it's essentially constant relative risk aversion from there. So what I do here is to pick a value of C, but somewhere between 1 and 0.5, and a value of relative risk aversion, and M, and then I calibrate the model using that value of R star at the bottom of this page. And then once I've calibrated the Weibull utility function, I have gamma, C, and then I plot the results for K and K over M for various values of M. So I'll find out what it shows. So really all I need to know is what value of R star I want to use. It turns out the literature's expanded considerably since my earlier work with Alan Garber. Some new work with Raj Chetty, the J.B. Clark Award winner, puts the relative risk aversion between 0.7 and 1. some Dutch panel and macroeconomic estimates, and even some estimates using with Gallup poll reports of happiness are pegging the R-star value between around 0.9. I'm going to use R-star of 1 in the simulations. Slightly smaller numbers are probably closer to the truth, but nice round number of 1. It's probably going to slightly inflate the K and K over M values compared to the slightly smaller R-star values. So here's the results. This is what it looks like when you plot this. Now I'm going to spend a moment describing these graphs. The bottom of these set of lines is C equals 1. That's the constant absolute risk aversion formula that Garber and I used. And you can see as you move up to smaller values of C, as the lines go progressively up to stack up to C of 0.5, that's essentially constant relative risk aversion at that point. I think there's good reason not to go either to those extremes. So the blue box in the middle sticks between the values of C equal 0.6 to 0.9, kind of intermediate values, and it brackets between the incomes of $40,000 and $60,000, kind of getting a range of median incomes from the U.S. and some major developed European countries. If you pick a central value of that, C is 0.8, $50,000 income, and R-star of 0.9, you get a value of K of $100,000. I mean, it's astonishingly close to exactly that. It's just a few dollars off of that with those parameter numbers. So let's now turn to the ratio of K to M. Again, the same parameterization. You can see the same values of C equals 1 to 0.5 going up as the stack rises from blue to green. Again, the $40,000 to $60,000 income range. And you can see here that the ratio of K over M, like the WHO ratio, gets up to 3 when you get income values of 60,000 and into the smallest of the C values that I'd entertain. And down at the lowest of 40,000 income, it's about 1.7 or so. But that blue box is kind of the relevant range. And again, right in the dead center of that in terms of where I think the parameters should be. If you pick the same C equals 0.8, 50,000 income, R-star of 0.9, you get this ratio of K over M, the cutoff ratio to income of about 2. Again, it's almost exactly 2 with those parameters. The key findings from this work in general, I said, just summarizing, at 50,000 income in these central parameters, the cutoff ratio to income is about 2. One of the key findings, and to surprise to me in some extent, is that both K and the ratio of K over M rise with income for all parameter values that I've tested. This is consistent with medical care being a luxury good. That is, you want more as your income climbs in a rapid. So basically, an income elasticity greater over 1 for medical care. It's also consistent with large employers offering an array of benefit options to employees, so they can pick and choose what values of stringency they want in their health plans. So it's quite consistent with that. Just a reminder that all of these values are driven by the opportunity cost of consumption, that elasticity of utility with respect to income. And because this is a particularly kind of specific functional form, the Weibull model, with only 2 parameters to calibrate it, I found that if you start moving too far away from the calibration parameter of 50,000 income and relative risk aversion of 1, things begin to look a little strange. So I would not extensively extrapolate beyond incomes of about $100,000. The findings are modestly sensitive to values of R-star. The appendix in my paper, which is available online, shows that. And they're somewhat more sensitive to the chosen value of C, as you could see in those pictures earlier. To really nail that down, we need better information about how relative risk aversion changes with income. We don't know that very well from the finance literature, and that would be one set of research areas to improve this approach. I would like to comment on what I think is a somewhat ironic result. In my closing remarks, Garber and Phelps had said, and it's been fairly widely cited, that we say that the optimal cutoff is about twice income. That was a kind of an eyeball estimate from Garber and Phelps. It actually turns out, in light of my current work, to be 2 offsetting errors. First is we use the DARA utility function, the exponential function with C equals 1, which gives us the lowest possible estimates among this family. But we also said that R star, the relative risk aversion, is about 2, which is far too high compared with current best evidence. And so these errors offset. And in fact, if you say in the Weibull model C equals 1, which is exponential, and R star is 1.7, you get the same value of K over M of 2. But I'd say it was the right answer for the wrong reason for Garber and Phelps. Last comment is you start to move from a single person, which these economic models do, to a societal model for picking a value of K or K over M. You have to ask, is this a single or multiple cutoffs? We have multiple in the US, for example. Medicaid is lower than Medicare or private plans in general in terms of stringency. And if we had have competing plans, as we would likely have in the US, I would expect to see a large array of plans with different options where the choices of K or K over M rose with income. Second question would be whether individuals can supplement the central plan or not. In UK, you can buy insurance for Harley Street medicine and EU tourism medicine, whereas Canada bans such insurance if the medical care is covered by their Canadian Medicare. And the question number 3 is how society would go about choosing this. Welfare maximizing models would have a substantially larger value of K over M than a median voter model, simply because the income distributions are skewed, and richer people, higher income people, want larger values of K. So welfare maximization would give you a larger cutoff choices than median voter models would. So with that, I'll say thank you for attention and turn the discussion back over to Steve.
Thank you very much, Chuck. That was great. I tell you, whoever that Phelps and Garber, whoever they were, they sure got lucky. I tell you, we should run them out of the business.
Yeah, well, I'm retired, so what's the? I got Garber's the provost of Harvard now, so you got rid of us.
Yeah, he had problems and ended up doing that. Yep. So, thank you very much. Can I ask you a question, because there are listeners to this both now and in the future who will not be health economists and for whom the equations will unfortunately be difficult to digest. If you were describing this to a person in the elevator that you just happen to bump into, and tried to describe how your approach kind of fit into the lexicon, if you will, of other approaches, what would your shortest version of this be?
I would say that everybody is trying to find some observable data to calibrate the cutoff value. Wage premiums for risky jobs is one approach. Mine is really just calibrating it's a hardcore economic model, but I'm just saying, let's follow that model down the path and see where it takes us and calibrate it with what we can with risk aversion, which will tell you a lot about it, at least some utility functions, including the one I've used. And if you want to follow the consequences of the pure economic model through, this is one way to go about it. If you think that's all hogwash, then this is probably not a very useful idea for you.
And when you say risk aversion, again, speaking to a lay person, how would you say aversion to what kind of risk are we trying to capture with it?
It's financial risk. It's why you buy insurance, to transfer that risk to insurance companies through risk pooling. And people we know all over the place are willing to pay to get rid of financial risk. How much they're willing to do that depends on how rapidly the marginal utility of income falls off as income rises. So, if you add $100,000 to your income and you make $50,000, you get a lot of gain in well-being from that. If you make $500 million a year and you get 100,000, you're probably not going to get much very absolute utility gain from it. And that's really what it's driven on. There is actually, if you've got another minute, can I have control back or flip to the next slide?
Yes, we will do that for you. There you go.
So here's a little pop quiz for everybody to do in the audience, which I think will answer your question, Steve. If your permanent real buying power were either go up, let's say by 10%, and you adjusted all of your spending to change, you changed cars, you moved into a new home or apartment, you changed how often you went out for restaurants, how often you went on vacations, how much would your happiness, your utility increase? Okay, so everybody get a number in mind for that. All right, now if that number, next slide for me, please. If you said 5% for a 10% increase in income, then that elasticity of utility with respect to income is 0.5. And if that's the case, then your K over M value is 2 by this model. Next slide, next deck. If you said 1%, then your utility hadn't changed very much with that addition of income. It's not very costly for you to give up consumption, and you'd have a K over M value of 10, the inverse of that 0.1 elasticity. And next slide again. If you said 0.9%, then you're giving up a lot of utility, and you'd have a very tight, small K over M. So it's really just sort of saying, how much is the opportunity cost of foregone consumption? That's the explanation that I would give. Sorry, that's not an elevator talk, but that's as close as I can do.
That's all right. My elevator moves slowly, so it was working for me. Again, just to be clear, because some people, especially clinically oriented people, might think that risk aversion has to do with risk aversion for health risk.
It applies to both. Darius Lakdawala and I have just finished a paper. It's an NBER working paper now. That's very heavy breathing mathematics. Unfortunately, it's hard to explain, but it basically shows how risk aversion and money and health are quite similar and can be translated one to the other.
All right. I was trying to put it historically into the context of some of the work that's characterized as, surveying individuals and how, as you said, how much income would they be willing to give up to avoid being injured at work or have some kind of health problem. As you presented this, it was clearly more around a more generalized effect around financial. Well, I guess there are various kinds of risk, as you stated. Yeah, Carl wanted to make a really quick comment, and then I do want to hand it over to Sean.
All right.
Chuck, it's kind of real quick. My interpretation of my answer to Steve would be that this is saying that healthcare is instrumental to survival, and survival is required in order to experience the utility effect of that change in consumption. Would you agree with that? If so, I think this is great. If so, maybe there's other things that healthcare does that maybe we haven't quite captured by treating it as just instrumental to continue to exist and been able to experience that utility.
Well, you put a harsh edge on that, Carl. The death rate is 1 per person ultimately. So we can postpone death, we can make life better or higher quality during our lifespan. And all those dimensions of adjustment are captured in the quality adjusted life year. So I guess I would temper it some. It's not like you'd give up everything to survive, because ultimately we don't. And we make a lot of decisions observably where we do things that make us happier but reduce our lifespan. Smoking, alcohol consumption, being most prominent among those. So we're always making trade-offs on those dimensions, either implicitly or explicitly. And you can make those, you can formalize how you think about those in economic models as long as you buy into the economic paradigm fully.
All right, great. Well, I'm sure we'll have time to circle back to the further questions and perspectives on that. But let me hand it over to Sean, and he's going to lead us through also a broader approach. And Chuck, thank you very much, and obviously stay on the line with us as we continue forward. Sean?
Great, yes, thank you. Like Chuck and Chris from the previous webinar, I've got some significant reservations about using the value of statistical life methods to derive a CEA threshold. Nevertheless, there is a fair amount of literature that describes how this might be done, and I want to give a brief introduction to that. This is not comprehensive. I haven't treated this as a systematic review of the literature. I will point out to those who would like to dive deeply into this literature that Carl pointed me to a paper this morning by Lisa Robinson and colleagues that's just come out in the Journal of Cost-Benefit Analysis that I think does a very nice job of summarizing the literature in this area. So I'd reference that, plus the extended body of work from Kip Viscusi. Okay, so I'll start with value of statistical life, and I'm recognizing that Chris spent a little bit of time talking about this approach, and so I expect he'll have some criticisms, as I do, of this particular approach. I would start by saying that issues pertaining to the value of life, whether it's statistical or otherwise, are very sensitive and probably the most controversial, or amongst the most controversial in the field of economics. Nevertheless, VSL has been used for quite some time in the U.S., particularly at the federal level. Specifically, the Department of Transportation, DHHS, EPA, et cetera, use these methods to value benefit assessment of interventions. The approach is relatively straightforward. The economic measure for considering optimal deterrence is essentially a risk-money trade-off for very, very small risks of death. And as a consequence of dealing with small probabilities, not the certainty of death, these values are often referred to as the value of statistical life. And the estimates of VSL come from market decisions that reveal the implicit values reflected in behavior, as well as survey approaches to elicit these money risk trade-offs directly. And again, I'm reminded that Chris had some very specific concerns about these approaches in his webinar that preceded this one. But government regulators, both in the U.S. and in other places, have used these estimates to value benefits associated with risk reduction policies. They are, in some ways, a reference point for the amount that a government should spend to prevent small statistical risks. Because the concern is with statistical lives and not actual known or identified lives, the analysis of government regulations now really use these methods to monetize benefits. I show a picture here from a magazine cover June 9th, 1985, when the Reagan administration introduced these approaches in the U.S., and it generated a fair amount of controversy and begged the question, what's a life worth? And there is a literature on sort of public response to having their lives valued by government entities. The economist Kip Viscusi has spent his career actually working in this field and is probably one of the most well-known and certainly the individual who cited most here. And I have two slides from a presentation he gave at ASH, the American Society of Health Economics, that I think summarize what he's found over time, which is first that the value of statistical life varies by age, and he's used two methodologies to approach this, an incidence-based and a prevalence-based methodologic approach. You see them both here. And then a translation of the value of statistical life into the value of a statistical life year, which gets you now a step closer to a quality-adjusted life year. A paper by Hirth and colleagues that was published in the Society for Medical Decision-Making journal in 2000 actually reviews the literature and puts forth, based on VSL methods, a cost per quality approach. And you can actually see this table here that I've extracted from the paper, and it shows the approach to computing VSL and then the translation of the value of life into a cost per quality. I think what's notable here is the range from 58,000 per quality all the way up to 1.2 almost $1 million per quality. Again, this was published in 2000, and some of these estimates come from the 80s. The paper I referenced earlier from Robinson and colleagues in 2019, just recently published, the Journal of Cost-Benefit Analysis, actually does a very nice job of extracting information on the U.S. government's, and specifically these agencies here, EPA, HHS, Department of Transportation, and then the OECD as well, extracting their VSL estimates and showing you the range here of estimates that are used. I will take the Department of Transportation estimates, 2016. These are essentially updates of Kit Viscusi's early work, showing a range of the value of a statistical life from 5.4 million all the way up to 13.4 million. Quite a large range. So again, I promise not to to dive too deeply into this literature, but I will summarize by saying there's a lot of heterogeneity in VSL estimates. And a lot of that has to do with methods, data sources, and the questions that are used for the survey methods, as well as the respondents' framing of essentially their response to the questions that are being posed to them with respect to willingness to accept risk. If you take the work that's published here and then translate it into a cost per quality, if you were to do that, it would give you, in sort of current valuation, about 100,000 to 300,000 per quality, roughly, from this approach. I want to mention a caveat here, and again, this is part of the value of sitting around the table talking with Jens and Carl, and this caveat comes from Carl, where he introduced the concept from John Broome that in actual social choices, once there is an identified individual, and Carl, correct me if I've got this wrong, there's an actual human being, then there is no amount of money that can be offered that can compensate for that specific death, which really makes using this approach problematic. Now I'll move on to whether actual resource allocation decisions can provide a framework to support a U.S. CEA threshold. The premise is that evidence from actual decisions that individuals and organizations make may potentially be more informative than hypothetical situations that are posed to people. And part of this actually comes from what is now well understood to be the urban myth that the 50,000 per quality threshold in the U.S. was linked to a political decision to expand Medicare to include renal dialysis back in the day that the ESRD program was approved in the U.S. Today, if you inflate that, the real value of dialysis is well above 150,000 per quality. If you try to find literature on actual resource allocation decisions and linking them to cost per quality, you'll find that there's very little. There are two notable papers I'd like to point out. The Breathwaite paper from 2008 that, and I'm hoping Dave Meltzer's on the line today because he was part of this work, and then Chambers, Newman, and Martin Buxton, 2010. Just a quick little introduction to both of these, and then I'll finish. The Braithwaite approach was intended to investigate whether this 50,000 per quality rule is consistent with decisions, resource allocation decisions that are being made. And they used actually two approaches, one to infer a lower bound and one to infer an upper bound. And I think the methodology here is actually quite sophisticated, very clever, and produced a conclusion in the paper that the $50,000 per quality threshold is inconsistent with observed spending behavior in the United States at the societal level. And I show you here in this slide, I think the key table, table 4 from that work. Here you can see the fruits of their empirical work that essentially using their methods, they arrived at a lower bound, that's their base case in panel A, of $183,000 per life year gained. These aren't quality adjusted, by the way, per life year gained. And an upper bound, that's the lower panel, using the incremental cost effectiveness from health insurance approach of close to $250,000 per life year gained. but a lot of variation, and they did a lot of good sensitivity analysis here. James Chambers and Peter Newman asked the question whether observing Medicare's national coverage decisions could lead you to the ability to impute a cost-effectiveness threshold for Medicare. They used past funding decisions or past coverage decisions. So these are national, and had, over the time period of the study, 64 coverage decisions that they linked with the availability of cost-effectiveness evidence from their database. What I'll show you here, I think, is the key table from that particular paper. There are, in the middle column, the number of national coverage decisions where the determination was positive. The very right-hand column was the coverage decisions that were negative, and the left side here is whether the cost-effectiveness evidence was dominant, less than 50,000, between 50 and 100, and above 100,000 per quality. And what you could see here, at least my interpretation of this, is that the Medicare coverage decisions follow a roughly a loose cost-effectiveness logic, but they also reflect a broader set of decision factors. And having sort of seen this here, it reminded me of some of the early analyses of the PBAC in Australia, where folk were trying to impute Australia's cost-effectiveness threshold by observing their decisions, and also concluded that the decision-making followed a rough logic, but you couldn't find a precise threshold. And Peter and James go on to conclude that there is no clear evidence of a CEA threshold for Medicare. Again, making it, I think, problematic to use this approach to necessarily inform a precise threshold. I'll finish with this slide, just a few concluding comments, and to sort of remind this audience who already knows this, that we live here in the U.S. in a very pluralistic, heterogeneous healthcare system comprised of many public and private decision makers, and that the work that ICER does, while incredibly important, is not linked to a healthcare budget, and ICER doesn't make purchasing decisions. And so maybe in the search for a threshold should not result in the articulation of a single threshold or even a range around a single threshold, but rather have the HTA report serve as a set of information that can be displayed across a range of thresholds. And I put, for example, here maybe from 10,000 per quality to 1 million per quality, so that the actual budget holders, whether they're public or private, can apply the evidence that ICER's generated around comparative effectiveness and CEA in a manner that's consistent with their own internal regulations, whether those are state or federal or combination of both, and their own market conditions, which includes the competitive conditions of private health plans competing with each other within states and regionally. All right, so I'll stop there.
All right, thank you very much. So we are now going to have responses from Chris McCabe and Jason Wasfy. Chris, you're up first if you're on the line.
Yeah, can you hear me?
Absolutely can. Forge ahead.
So I will try to be brief. I'll start off with thanks. It's been a real, it feels like a real privilege to have a reason to take time to get my head around the work that Chuck and Sean have presented. It's as we all know, it gets harder and harder to actually carve out time to engage properly with detail. So thanks for giving me a reason to do that. Great presentations from both of you. I'm going to start briefly with some comments on Sean's presentation and specifically mostly around the value of statistical life. approach, a bit more. I'm going to put another nail in the coffin of this approach, I think, and then slightly perversely maybe pull one of the nails out. And then I'll go to some questions I have for Chuck, which are more to do with applications of his work. I think it's just a stunningly useful and insightful addition to the literature. So thank you for that. I've got some questions about how we use it in an ISA-like context. So value of statistical life, as Sean highlighted, all that literature is about small changes in the risk of death, unidentified people. And I think the more I think about the sort of technologies that ISA are facing, these increasingly expensive and personalized technologies, I think there's a fundamental philosophical question about whether actually the risk of death, the risk of harm, or the avoidance of harm is to unidentified people. For lots of the decisions that ISA and similar organizations are dealing with. You know, the Duchenne muscular dystrophy are very visible, very identifiable people. They make themselves identified. So there's a fundamental question, I feel, about the relevance of evidence that's about small changes in risk of bad outcomes to unidentified people. So I think that's kind of another sort of fundamental philosophical reason why we could say the evidence on the value of statistical life is often not relevant to the types of decisions that organizations like ISA are dealing with. Did say I'd pull a little bit of one nail in the coffin, maybe try and pull it out a bit more. And Carl sent us all round the Broom paper, which I hadn't actually read since I finished my PhD 15 or so years ago, and it was great to go back and remind myself of his argument. And I think a little noticed but really important caveat or condition of Broom's argument that there is no value once we know who the individual is. He just says in passing, very briefly, we assume no bequests. Of course, there are bequests. In the real world, we see individuals maybe choosing not to mortgage their houses, sell their houses, release assets to fund their own healthcare so that they can pass on those assets. Even in a social system, a decision not to pursue a highly expensive line of treatment is actually a de facto bequest to other members of the society, the population covered by the payer, and we have evidence. It may well be cohort effects. There is a concern, but we have evidence that older people will choose not to pursue expensive lines of therapy. They have I've had my fair share. I would rather leave things available. So I'm not sure. The moment it's identified, the individual is identified, it's a slam dunk infinite figure, actually kills off the value of statistical life, because I don't think that's what we observe in human behavior. That said, for the other reason, I do think we should set aside the value of statistical life. So that's my comments, final comments on the value of statistical life. In passing, I think any of these estimates of the observed, eliciting an estimate from observed decisions, it's always going to be subject to criticisms of unknown confounders. Anyone, and I think most people in this around this table have been in the room where these sorts of decisions are made, and often not all of the information or considerations that have influence the decision are necessarily in the public domain, and so there's, I think, a significant issue of unknown confounders. And if ISA is trying to arrive at a figure that it can defend publicly, I think it would struggle to get past criticisms of unknown confounders if it was to use values deduced from observed decisions. So that's my final comments on those issues. Turning to Chuck's model and presentation, my questions are, as it says on this, I sort of got two groups of questions. One's about the model, or really the inputs to the model. And if I'm honest, it's really one input to the model. And one is about using it for societal decisions. So, these are, it's pretty standard hardcore economics. We're looking at marginal changes. The reality of healthcare is these healthcare expenditures, most healthcare expenditures, if done without insurance, would be catastrophic expenditures. Are our attitude to risk of extreme events consistent with the more marginal changes, our risk over marginal changes in income? The psychology literature would indicate not. So my question is, what would be the impact of incorporating evidence on our risk aversion for catastrophic changes in our income into the model and thereby onto the threshold? So that's my first question. I don't know the answer, but I think it might be pertinent to explore it. My second question is about classic economics. It's about the individuals, and we get, Chuck's final slide sort of goes straight from the individuals to society, and I wonder whether actually household is a pertinent unit of decision making which we might want to think about. How insurance is not infrequently held at the household level, family coverage, etc. And risk attitudes, risk aversion with regard to our children's expected lifetime income is probably different from our own. I posit that as parents, we're quite often much more risk averse over our children's health, and I'm that's linking that into their expected lifetime income for the model's purposes. So how would adopting a household model of risk aversion, and I suspect there's no data on that, but conceptually, how would it change if we said these decisions are being made at a household level, and can we see risk aversion at that level and incorporate it into this model? What would be the impact on the threshold? Again, I don't have a prior, I just have a question. Given it's a classic economic model all about the individuals, the value of solidarity with our fellow citizens isn't in there. Whilst the US is as individualistic as any OECD nation, there is still, I think, prima facie evidence that there is a value in solidarity. The Medicare, Medicaid, right to emergency care, all of that indicates there is some value attached to social solidarity. And so my question is, would this fact make the model less pertinent, less relevant to making recommendations for socially funded payers, providers such as Medicare, Medicaid, and even Veterans Affairs? Those are my questions. Can I move on here?
Thank you.
I got
Chris, Chris, given the amount of time we have left, I'm actually going to, why don't we focus on those questions that you've asked. I want to give Jason Wasfy a chance too, but quickly, obviously, because those are questions for Chuck largely. Chuck, do you have a quick come back to those three questions, if we can go back on the slides? There we go. Chuck, you want to try to very briefly, and you may not be able to do all three, you want to pick one or two favorites and give a quick response?
I think I can touch on all three of them. I was taking some notes.
Okay.
First of all, the catastrophic risk aversion question, you really need to turn to new work that Darius Lactawala and I are doing to deal with that. My model is expected utility. In concept, it's the same cutoff across all sorts of risks, but you have to begin to incorporate the risk and in the case of what Darius are doing, variance and skewness and possibly even kurtosis of distributions of health outcomes into it. And I think that's a better way to think about this catastrophic expenditure question than trying to build it into the cutoff itself. I'd keep the same cutoff, but I'd build the risk into the value model. The second one, household risk aversion. Nobody's done that. I've been doing some work in social choice. I'd say I might think about the family as a small society where people voted and had perhaps different weights in terms of how much their votes counted, or a benign dictator where the parents are more concerned about their children. But it's a social choice question within a small society. And in terms of the third question, I'd say the model directly informs Medicare, Medicaid, and so on in a couple of ways. The most obvious is that there's a strong income relationship in picking the optimal cutoff. It would tell you that the Medicaid cutoff would optimally be lower. The lower income people would rather have a smaller cutoff and more income on other sources in terms of redistribution. And the work, again, that Darius and I have been doing can deal with the issues about severity of illness. Particularly, we know that there's more value for treating severe illnesses in that world. But again, that's all pretty hardcore economics. But that would be the ways I would address those questions from Chris, and they're very interesting questions.
All right. Thank you very much, and also for being so succinct. That was very helpful. So we have some time now to hand it over to Jason Wasfy. Jason, you want to introduce yourself, and then have any comments that you may have.
Oh, can you hear me?
Yes, we can.
I'm Jason Wasfy. I'm a assistant professor of medicine at Harvard Medical School. I'm vice chair of CPAC. I'm a clinical physician who does a lot of health services research. These presentations have been wonderful and have pushed me to kind of recall from being grad students some of the sort of important methods issues with the willingness to pay threshold. And I think there was a couple of things that resonated from, we just had a CPAC session yesterday, and I guess I would just start by saying that I think one thing that I have been constantly, I'm not sure if it's good or bad, it's just an interesting thing to me, is that especially as someone who, I'm an unusual guy in the sense that I'm a physician who's trained in decision analytic methods. I think that it's astonishing how many times in these public sessions people make comments about decision analytic models, or even using health economic models to inform clinical decisions and make recommendations on price without quibbling about the specific inputs in the models. I mean, the way I was trained, I think the secret sauce are in a lot of the assumptions that are made, including the willingness to pay threshold. And I'm not sure if we're at the stage yet, at least I haven't really seen it, where people, industry groups or patient advocacy groups have come specifically with methodological criticisms, like real methodological criticisms, as opposed to simply saying that qualities don't capture this or that. So to whatever extent, and I'm not sure there's an easy answer here, to whatever extent we can incorporate methods that are explainable to these audiences and comprehensible, I think would be critically important. I think to that end, especially with respect to varying willingness to pay thresholds, there's no question in my mind that reporting results from these models across a varying willingness to pay threshold would be more rigorous and maybe more flexible in applicability, because different insurance companies could say, oh, well, based on this local conditions or based on what we're willing to pay in this market, that such medication would be either cost effective or not cost effective. And my concern is just in the practical sort of implementation of these in our reports, simply because it's just much easier, for example, in the media, for the media to understand that something's cost effective or not, rather than it's cost effective at very high or very low thresholds. There was one yesterday there was one example of something that effectively would not be cost effective at any willingness to pay threshold, even if it was sort of extending death to perfect life over 40 years. And that I think resonated to me in terms of varying willingness to pay thresholds, because it really illustrated an important point. And then I guess the last thing I wanted to comment on hearing these talks is the concept of household risk aversion. I mean, it's partially, again, because of the session that we just had yesterday, it's sort of on my mind. I do think, I don't know the empirical evidence for this, but I'm nearly certain that the empirical evidence exists for what you said, which is that different age groups have different risk tolerances for their own healthcare decisions at different stages of life, and we all sort of would tolerate higher prices, for example, for our children than elderly people, for example, would for themselves. And that may be a nice way potentially for sort of trying to deal with the issue of having the concept that like a child's life could have a different willingness to pay threshold than an adult's life. It's something that I think is sort of, crosses our minds sometimes, but a household risk aversion sort of in totality would be one methodological conceptual way to do that. So those are my comments. I have found these talks incredibly helpful, and also just would thank ICER for sort of these webinar series, because I think that sort of refining our methods and sort of having these eminent health economists and people who specialize in decision analytic methods is sort of unusual. I think Steve, you're recording these, so I think this is going to be a really good resource for lots of people in the years to come.
I hope so. Thanks, Jason. So we only have a few minutes left. I wanted to take the prerogative of asking kind of a provocative question based on the insight that often the real data that we have that could guide some of the decisions around thresholds ends up with a conclusion that makes us very uncomfortable, at least in this country. So if you were actually to tell people that poor people want a lower cost effectiveness threshold because they need money more for other things, and rich people, because they have so much money, are much more willing to spend it on higher kind of ICER services, you create a world that seems to accentuate in some people's minds the worst of the inequality of income effects in our overall society. So it may be very true, and yet it may be a conclusion that will not be compatible with the way that people will want to structure the way that we assign thresholds and apply them in our decision making. So it's just, there's always that tension where we can find situations where we're confronted by the facts not being the world in which we want to live to a certain extent. So Carl, believe it or not, Carl, I'm going to ask you a question. And you cannot, no,
ask me that one.
But you have to answer my question and not what you want to say. And then we have like 1 minute left. So this prior funding, because in the U.S. context, it's very easy to say, well, look at all the things that we do of extremely high ICERs, low cost effectiveness. That is in some way a reflection of reality, of our willingness to pay. And so any kind of constraint on that is just, it must be for somebody else's purposes of reducing budgets. It can't be really reflective of who we are as a people, because we're willing to spend $1 million per QALY or more many, many times in many different situations. You can make one argument that for efficiency frontiers to deal with that situation. But Carl, you're in the UK system where, as we'll hear on the next webinar, opportunity cost is often viewed as the core funding or foundational principle of the way that thresholds are set. So how do you respond when people inside the UK system find services that are at very high ICERs? Do you tell them that that was just a wrong decision to make and they're actually losing health elsewhere and we shouldn't have done that? Or what? What do you say?
I say we have chosen to band together in the UK, and we have a single payer system, and we vote for a government that decides how much to spend on that. And what that means is that we're all in it together. And for sure, you want this healthcare and you've got some health benefit, but you won't pay for it. Other people will pay for it, and they'll pay for it in increased mortality, reduced survival, and reduced quality of life outcomes. And I can show you evidence about how many people that's going to be. So either we vote for more taxes, or we cut the prices to make this affordable. But you know what we won't do is to make decisions where one benefits, but other people lose out to a greater extent, because although you're identifiable, these people over here, we don't know who they are. But one day we'll find out. They'll never really know that they paid the price, but we know they will pay the price.
So that's an introduction, obviously, to next week's discussion. But have there been specific services that have been provided, are being provided, and will be provided in the NHS that are recognizably much higher than the effective cost effectiveness threshold? And is that a mistake, or is that a reflection of something else that makes them correct?
There are plenty of examples, and dialysis is the classic one. Now, what explains that? What explains that is that there are other attributes of outcome about the type of health, the type of people, and the burden and the consequences they face, which means we collectively have decided that in this particular case, it is worth it, that other people should give up life expectancy to make sure these people stay on dialysis. But we make that an explicit decision that's weighed and that's accountable.
All right. So thank you, and I'm sorry we've run over time. I do want to give one last quick word, if you'd like to have it, if they would like to have it, quick to Sean. Any last comments, and then Chuck, and then we'll wrap it up.
None for me.
You're good? Okay. Chuck, any last comments?
Carl raised an issue which I think deserves some attention, and that is that once the life becomes identifiable, things change. One of my great concerns about the value of statistical life is that it is anonymous and very small probabilities. The strong economic logic says that once an individual is identified, you are looking at the willingness to accept a risk. All of that value statistical life literature is on wages is really willingness to accept a risk, not willingness to pay to avoid them. And you know, you might be willing to pay a large amount to avoid a risk, but it would take an infinite amount for you to willingly give up your life. That's my major concern with the value of statistical life literature, is that it's measuring the wrong concept. It's measuring willingness to accept rather than willingness to pay.
Great. Thank you very much. And again, thank you for tuning in to these webinars. The next one, next week on July 30th, is going to be opportunity cost, which we had a brief early vision of today. And the presenter there, the lead presenter, will be Carl Claxton, with responses from Sean Sullivan and Lou Garrison. Thank you very much again, and we'll hope that you can make the rest of the webinars. Have a good day.
Thank you.